Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Lilly.
Hello, I'm Stephen Johnston, Professor of Breast Cancer Medicine and Medical Oncologist at the Royal Marsden Hospital in London. Welcome to this program entitled Expert Perspectives on the latest clinical data updates in hormone receptor positive, HER2-negative, early stage breast cancer. Today, I'm joined by Dr. Priya Rastogi, who is Professor of Medicine at the University of Pittsburgh School of Medicine and the NSABP Foundation. Welcome, Priya.
Hi, it's great to be here today.
Good. So, as we know, there have been major leaps in the treatment of early stage hormone positive, HER2-negative breast cancer. We now have many more options for these patients than ever before. So, we're going to spend a little bit of time today talking about the recent clinical trial data and particularly around the role of adjuvant CDK4/6 inhibitors in this setting. But within this context, it's important to really understand risk factors for recurrence, assessing what the accurate risk of recurrence for a patient is, and then having the ability to offer more treatment options for those patients. Now, we know that there have been a number of key trials, and the two big trials with CDK4/6 inhibitors are the MONARCH-E trial using the abemaciclib and the NATALEE trial more recently reported with ribociclib. The MONARCH-E trial had node-positive patients, either 4 or more nodes, or if 1 to 3 nodes, then either a grade 3 tumor or a large tumor size. There was a smaller cohort of lower anatomical risk but increased biological risk on Ki-67. NATALEE had a wider group of patients, basically stage 2 and 3 disease, including lymph node negative patients at increased risk. And we'll go into the details of those a little bit more shortly. On this slide is evidence also of other ongoing trials, knowing that this is still a very busy area in hormone-positive, HER2-negative breast cancer, particularly with therapies called SERDs, selective estrogen receptor degraders. And these are the trials to watch out for over the coming few years, because we continue to push the frontiers forward, and these may be even more effective endocrine therapies than our current options of aromatase inhibitors and tamoxifen. And all of these studies are looking in medium to high-risk patients whether we'll have an even better endocrine partner to take forward in the early breast cancer setting. So it's a very busy area, but today we'll focus mainly on the data with CDK inhibitors. Now, let's just talk a little bit about the MONARCH-E trial, which basically was node-positive patients. And the cohort 1 was 91% of the patients. And as I said, these were 4 or more nodes, or if 1 to 3 nodes, at least one of the other factors, either grade 3 disease or a large tumor size. And we know from historical data, NSABP trials, GICAM trials, that this is associated with an increased risk of recurrence, even despite conventional chemotherapy and endocrine treatment, which could be up to 20-30% at 5 years. So these are patients with an unmet need who need additional therapy. The second cohort, as we can see, was higher risk based on biology, not necessarily anatomical features. So only 1 to 3 nodes, perhaps a grade 2 tumor, not a large cancer, but an increased proliferation. And it was only around about 9% of patients, and it was a second cohort added on. You can see that this was an open label study in 5,500 patients who, once they completed their standard of care surgery, chemotherapy, which was given in 90% of these node-positive patients, 95% actually, and radiation therapy, were randomized to either endocrine treatment alone, potentially up to 10 years, or endocrine therapy plus 2 years of abemaciclib, 150 milligrams BD. So that was the design and randomization. And these patients were all staged at the outset to show no evidence of metastatic disease, but deemed to be high-risk patients. So the trial outcomes are shown here, and these were the latest data published by Dr. Rastogi in the JCO last year, and represent the 5-year data now for Monarch E. And it is a positive trial. There is clearly significant improvement by the addition of abemaciclib to endocrine therapy, which is the red line, compared to endocrine therapy alone, which is the blue line. And I'd just like to point out a couple of things on these data slides, which on the left show invasive disease-free survival, and on the right, the secondary endpoint, distant relapse-free survival. The first thing is if you look at the blue curve, the rate of progression and relapse in these patients is steady. It's a straight line, and it's year on year, these patients who are at greater risk relapse at a steady rate, such that nearly 1 in 4 have relapsed by the time they get to 5 years. And that's despite the majority all having received chemotherapy and appropriate radiation and endocrine-based treatment. And then the second thing to notice is that the curves separate relatively early at around about 9 or 12 weeks and continue to separate even after the 2 years of abemaciclib therapy. This is what we call the carryover effect, where the benefit of the addition of the CDK inhibitor continues beyond completion of treatment, suggesting that a cohort of patients are clearly prevented here from having recurrence of their disease. So it overall represents a 32% reduction in risk of cancer coming back, and that's matched by the distant relapse-free survival. So this is a very clearly significant positive result, which is a real big milestone in the improvement of outcomes for these patients. Now, if you look at cohort 1, which was the 4 or more nodes or 1 to 3 nodes with large grade 3 tumors, then this is the endpoint that you see here, that the absolute improvement is just about 8%, 7.9 to be precise, and that the number of patients relapsing at 5 years was 25%. So of those 25% who were relapsing, so 1 in 4 on endocrine therapy alone, a third of them, so that's 8 of the 25, are prevented from having cancer come back by the abemaciclib. And those are the way I explain it to patients. I say, look, you've got an increased risk. There's a 1 in 4 chance that the cancer might come back if we just have standard therapy. And of those 25% where it's going to come back, a third of them can be prevented by having the addition of abemaciclib. And that's a figure that I think patients as well as clinicians can easily understand. Now, the benefit was seen in all the pre-described subgroups, as you can see in this forest plot, particularly in premenopausal women, and particularly those who had large tumors and perhaps had their chemotherapy in the neoadjuvant setting. Here, the hazard ratios are very strong. And so these young patients with large node-positive cancer who perhaps have neoadjuvant chemotherapy, but will know they still have residual disease at surgery, because that's common in luminal breast cancer, these patients are still at increased risk, and the addition of abemaciclib in these patients is particularly effective at reducing that recurrence. But the benefit is seen across stage, grade, and nodal burden. Now, in terms of overall survival, the data are immature at the current point, because in early breast cancer, it takes a long time before you see an impact on survival from an adjuvant treatment. But we're starting to see a numerical difference in the number of deaths, 208 in the abemaciclib arm, 234 in the endocrine therapy alone arm. The hazard ratio confidence intervals just cross 1, and we need more mature follow-up, and it is an event-driven analysis, not a time-dependent analysis. So when the number of events in the statistical plan is reached, we'll have clarity or not about the survival benefit of the addition of abemaciclib. Now, the other trial to mention is the more recently announced NATALIE trial, and this was a similar phase 3 trial, randomized, open-label design, looking at the addition of a CDK inhibitor, this time ribociclib, which we know is a different drug, given on a schedule of 3 weeks on, 1 week off, because it has more hematological side effects rather than abemaciclib. There are 2 key things to notice on this particular design, which are different to Monarch E. Firstly, the dose of ribociclib at 400 milligrams is lower than in the metastatic setting, and that was chosen specifically to reduce the incidence of neutropenia and dose reductions that were occurring at the higher dose. Secondly, it's a 3-year treatment period, not a 2-year treatment period. And whether that is relevant or not, only time will tell. Patients here were all either stage 2 or stage 3. And in the stage 2A patients, if they were node negative, they had to have an additional risk factor, either grade 3 or if grade 2, either a high proliferation score or an increased genomic score on Oncotype or other platforms. Node-negative patients who were stage 2B or 3 were also allowed in as well. So there's a proportion of node-negative patients with increased risk based on either anatomical stage or of low anatomical stage, increased biological risk. The endocrine therapy here was also predetermined to all be aromatase inhibitors. So in premenopausal women, they had to have an LHRH agonist as well. So there was no tamoxifen in this trial, unlike in the Monarch E. So the data are positive in this trial, and they were updated at the ESMO meeting in September 2024. And we now have secure data out to 4 years. So not quite as mature as Monarch E. And overall, in the intent to treat population, you can see an absolute improvement at 4 years of 5%. Overall, the patients in the control arm are doing a little bit better than on the Monarch E trial because includes a slightly lower risk group of patients. But the hazard ratio here of around about 0.7, so a 30% reduction in risk of recurrence, is a relatively similar magnitude of hazard ratio. And you can see the difference in the distant disease-free survival as well. Now, in terms of stage, whether it be stage 2 or stage 3, again, hazard ratios are relatively similar. Stage 2 patients have a slightly better prognosis than stage 3. And the other thing of interest to see is that we're starting to see that separation of the curves. Here you have 3 years of treatment, not 2 years of treatment, but beyond 3 years, out to 4 years, the curves appear to be separating out. So this carryover effect that we saw in Monarch E does appear to be occurring in Natalie as well, which is really interesting to see. But both of us wanted to see what's the benefit in the node negative patients. They represented about 12% of the overall trial population, so a smaller group. But again, here a hazard ratio of 0.66, wide confidence intervals because the numbers are smaller and the events are fewer, but an absolute difference here of a similar level out at 4 years. So the drug appears to work in node negative patients selected appropriately for higher level of risk. Likewise, the overall survival data are immature at this current time point, but the hazard ratio is pointing in the right direction. The numerical number of deaths is fewer, 105 versus 121, but further follow-up is clearly needed in this setting. So those are the data slides, and Priya, really, let's start to think about how we can apply this data in our patients. So I'm going to give you a 62-year-old postmenopausal patient who has a tumor that's a T1N1 tumor. So relatively small, less than 2 centimeters, one node positive, and it's a grade 2 tumor. Hormone positive, slightly lower PR score, HER2 negative, but a key 67 of 18%. So not a high risk on a key 67, definitely a grade 2, a smallish tumor, but one node involved. So what do you think about, is this an increased risk patient? How would we treat this patient? Do they need a CDK inhibitor? And if so, what?
Yes, so with this patient, she would have met the criteria for eligibility to receive ribociclib with an anti-estrogen, but not would not have met eligibility for the monarchy study. So she would be able to receive ribociclib with an aromatase inhibitor at the current time. So this is a really nice slide in terms of looking at the differences with this study. And so, as we have discussed with monarchy, for those patients that were eligible for the study, the patients had to have at least 4 more positive nodes or 1 to 3 nodes with at least one of the following. So, grade 3 disease or a tumor of at least 5 centimeters. And then, as Dr. Johnston has mentioned, that there was a smaller cohort that also could have received abemaciclib with endocrine therapy that had 1 to 3 nodes positive with a Ki-67 of at least 20%. And so this is reflected in this chart that you see in the green with the monarchy study. Patients had higher risk disease and were node positive. With Natalie, those same patients were eligible, so the stage 3A, 3B, 3C, but Natalie also captured a lower risk patient population in terms of the patients with node negative disease. And that's one of the biggest differences with the two studies. So, just to review the patients with the lower stage disease for Natalie, again, patients with 2A disease, if they were N1, the patients were eligible to participate in NATALY, but also the N0 patients with another high risk criteria. So for N0, they had to have either grade 2 disease with another high risk feature, so a Ki67 of at least 20%, or high genomic risk, or could be grade 3. So, really important differences with this study, but really expands the use of CDK4/6 inhibitors, particularly in the stage 2 no negative patient population.
Yeah, I think this is really important. And one of the key issues in tumor boards, Priya, is whether this is really easy for folk to work out because, hitherto with monarchy, it was pretty straightforward, four or more nodes or one node, 1 to 3 nodes, large tumor or grade 3. Do you think the Natalie criteria, because, we don't necessarily all use the staging system 2A, 2B, in my practice anyway, but people understand grade, size, and to some extent proliferation markers. Do you think this will be fairly straightforward for people to understand and identify who those patients are?
I think it'll take some more education, as you mentioned, especially with the anatomic staging related to actually what size of tumor did the patient need to be for to be eligible for Natalie, and then even especially for the node negative, both the size of tumor and then the high risk feature. So I do think these pieces will be important in terms of education.
Yeah, and the patient we've just discussed, the T1N1 patient with a key 67 of 18%, what do we think that level of risk for that patient is? Because if you had her in the clinic, how would we be sort of saying, you have got an increased risk? You may or may not need chemotherapy. That's a separate issue that we obviously work out based on, in these N1 patients, perhaps a genomic assay. But how would we assess what a level of risk is? Would we rely on the information from something like an oncotype? Or do you think we can actually say, look, your level of risk is X?
I think that's a great question related to the level of risk. And as you had outlined very well related to monarchy, it's a lot easier with the node positive. But the node negative, they may have the same relative risk reduction, but it'll be more interesting to see with the absolute risk reduction. How do we explain that to patients?
Yeah, I think that's really interesting. And I'd like to share some data that was presented at ESMO by Dr. Kamal Javajiri from a Flatiron database, because I think this is really fascinating because it really does identify in a wider population of real world patients, not necessarily treated with CDK inhibitors, which I think is very important in the education, as you say, Priya, as to what patients' level of risk is. So I'll just walk people through it. Basically, you can see in the solid lines here, which relate to either N0, N1, or N2, 3, the level of risk of recurrence at 3, 5, and then 7 years. And you can see as nodal burden increases, the risk of recurrence increases. And this is well known in breast cancer. But focus on the N0s. Overall, at 7 years, a 7% risk of recurrence compared to N1, a 17% risk of recurrence. But we know the N noughts, if you layer on top biological risk in addition to their node negative status, things change. And if you look at those high risk node negative patients based on the criteria used in Natalie, which is either grade 3 or if grade 2, high genomic risk in terms of oncotype, more than 26, or a key 67, more than 20%, you can pull out 12.2% of the node negative patients who are now called high risk node negative, as opposed to low risk node negative, where they don't have those biological high risk features. And look in the subtext here how that changes things. you can see that those high risk node negative patients, so only about 12% of them, their risk jumps up from 7% overall to nearly 17%, 16.9%, exactly the same as the N1 patients. Whereas the overall risk of recurrence of the N naughts who have low genomic risk features, low Ki67 and a lower oncotype, all of a sudden there's only 5 or 9%. So I find this data fascinating, Priya. And do you think that people know this? Because this was a large US database in Flatiron, wasn't it, of a significant number of patients. But this is real world data. And I think this is instructive in making people really understand their node negative patients. What's your view on this?
Yeah, I completely agree with you. And it will be really important in terms of education related to the high risk node negative patients and what their risk really is in terms of also helping with intervention with the anti estrogen, but adding in ribociclib in these cases.
Yeah, so I think that's really helpful data. And I think it also, to me, really reinforces that because there's a lot of concern that in Natalie, we're going to flood the market with all node negative patients being offered a CDK inhibitor. And I think it's really important that those node negative patients are really identified as the high risk ones, based, as you said, Priya, in that table, either on a larger anatomical tumor size or if they're the stage 2As that they have increased biological risk. And I think if that is undertaken, we can really identify those patients. So, Priya, I'm just going to give you another case to sort of just thrash this discussion out about these treatments. And this is a slightly different other end of the spectrum in terms of biological and anatomical risk. So here we have another postmenopausal patient, 68, and she's got a different type of cancer, stage 3A. So T1N2 and a grade 3 tumor, high Ki67, 40%, ER75, PR low, HER2 plus. So really, what do you think here is going on in terms of her level of risk and her options?
Yes, so in this case, which is very different from our first case, the patient has a higher stage, so 3A, T1 and 2, grade 3, and then a high Ki67 of at least 40%. And so in this situation, the patient would have been eligible to participate in either the Natalie or the Monarchy study. And so you do have some options there with this patient and her level of risk. I really do like these NCCN guidelines, and I think it helps in terms of what we were discussing before, especially with the ribociclib, to really delineate which patients are eligible to receive ribociclib. So first, we'll go through the abemaciclib. So category one preferred patients can receive 2 years of abemaciclib in combination with endocrine therapy. Again, for patients who are high risk, and this is defined as at least 4 positive lymph nodes or 1 to 3 lymph nodes with either grade 3 disease or a tumor of at least 5 centimeters in size. For ribociclib, also category one, patients would receive ribociclib for 3 years with an aromatase inhibitor. And this can be considered in patients who have positive lymph nodes, or if no lymph node involvement, at least a tumor size of greater than 5 centimeters, or a tumor size of 2 to 5 centimeters with grade 2 disease and high genomic risk, or a Ki67 of at least 20%, or grade 3 disease. So for me, when I looked at these NCCN guidelines, it really helped me to delineate, okay, what are we looking at in terms of size of tumor? And for those 2 to 5 centimeter tumor size, which high risk patients would be eligible? So I found this actually very helpful in terms of size and patients with no negative disease.
So this patient, therefore, kind of meets the criteria, doesn't she, for either abemaciclib or ribociclib? So, what do you think are the factors that clinicians need to think about, Priya, to go into the decision making about which CDK inhibitor to use here?
Yeah, so what's really nice here is now that we have the choice for these higher risk patients, there's many items to take into consideration. One is the follow-up time with Monarchy and Natalie. The Monarchy data, there's more follow-up at this point. So the median follow-up for Monarchy was 54 months, and for Natalie, 44.2 months. So this is something to take into consideration. Also, the duration of therapy is a really important discussion to have with the patient. So, with Monarchy, the abemaciclib was given for 2 years. With Natalie, the ribociclib was administered for 3 years. So, this may play a factor. Another item to really take into account is that for some patients who cannot tolerate the aromatase inhibitors and would need to receive tamoxifen, those patients would not be a candidate to receive ribociclib. And in those situations, it would be better to give abemaciclib with the tamoxifen. The most common side effects, which are another factor to take into account when you're educating patients, is with abemaciclib, we saw in Monarchy diarrhea, fatigue, to a lesser account, but we still saw some neutropenia. For ribociclib, in the Natalie trial, there was neutropenia, arthralgias, and nausea. In patients who, for whatever reason, have diarrhea at baseline that may not be well controlled for whatever reason, they may not be the best candidate for abemaciclib. Although we do know with Monarchy that the side effect of diarrhea is well controlled with anti-diarrheal medications and dose reductions if needed. And then, in terms of comorbidity or adverse events, patients in the rare event that they may have a baseline risk for a prolonged QT interval, they may not be the best candidate for ribociclib, and that's where you may consider abemaciclib. It's very important to have these discussions early on in the patient's care. So, even as they may be receiving chemotherapy, if it's indicated, or during local regional therapy, especially surgery or at the time of radiation, because when you're upfront with the patient at these earlier time periods, they have time to process the information. They usually know they're going to be receiving some sort of endocrine therapy, but then also this added CDK4/6 inhibitor helps in terms of for the long run in terms of adherence and also managing side effects.
Yeah, I think those points are really excellent. There's a couple of things I'd like to add to that. I think as far as the diarrhea with abemaciclib, which can be a concern for clinicians as well as patients, two key messages are education and spending that time with the patient up front about the measures to take, co-prescribe the loperamide up front to go with the first cycle and start it at the first sign of a loose stool, which normally comes on around about a week later and lasts a few days. And then, secondly, to know that it's really important to dose reduce if needed. In the trial, we had 40% of patients going down to a lower dose. And we published last year the data that even if the patients go down one or two dose levels, their benefit is exactly the same as the patients at the full dose. So you don't lose the benefit by reducing the dose. It's the ability to stay on the drug, not the absolute level that you're at. And I think that's a really important message to give to patients. And you have to have that close communication with your team or your nurse specialist with the patient in the first 1 or 2 months to get the dose level right. And then when the dose level's right, you really very rarely have to make any further changes. So I think that is effort and time well spent in making sure that you stay on the right dose, and then people can adhere and stick to their therapy.
I also want to mention the trade trial, which was presented at this year's ASCO conference, which explored dose escalation strategies for starting abemaciclib. The goal of the study was to help with patients to better tolerate the treatment and gain confidence while managing potential side effects at home while they gradually increase the dose. So here's how the dose escalation worked. Patients started at 50 milligrams twice a day for the first 2 weeks. Patients then were increased to 100 milligrams twice a day for the next 2 weeks. Finally, patients were moved to the full dose of abemaciclib, which is 150 milligrams twice a day. This step up increased approach allowed patients and their bodies to adjust, and the results were very promising. Approximately 70% of patients reached the full dose at the 12-week mark, and 93% were still on therapy. This suggests that a dose escalation strategy could be highly effective, and it's a way to improve treatment adherence for patients receiving abemaciclib.
I'd like to point out and interested in your view on this, Priya, is that obviously the other reason for discontinuation with ribociclib was around about 8% get a grade 3 transaminitis or elevation of liver enzymes. It's much more common with this drug than with the other CDK inhibitors. And although it can occur that you can stop, dose reduce, and so on, it may not work in all patients. And Priya, knowing that they can change from, say, the ribociclib to the abemaciclib or the other way from the abemaciclib to the ribociclib, I think that's really important freedom for clinicians to know we've got more choices now.
I agree with you. I think that is a really important point in terms of that there are choices. If a patient isn't able to tolerate one of the CDK4/6 inhibitors, they could potentially switch to one of the others. And also can't agree enough with you related to the dosing. I've had patients who've been concerned about having a dose reduction, and that data was so critical that even if you have a dose reduction, there's similar efficacy even a lower dose. Are really important discussions to have with the patient related to efficacy and side effects with both these medications.
And these are clearly important additional therapies for these patients when we can identify the ones that are at greater increased risk. So, Priya, I think our time is up. Thank you for a great discussion, and thank you to all participants for joining in this activity. Please continue on after this to answer the questions that follow as part of the CME evaluation, and also complete that evaluation for us. So, thank you very much, Priya. Thank you for the audience for listening, and I hope you all found the content helpful and instructive.